Dr. Priyadarshini, the course director for Study EFOG at Study Medic. And in today's YouTube series, we are going to see on the module Labor and Delivery, and we are going to discuss some important SBAs and EMQs on how to tackle them in the exams. Winners are not people who never fail, but people who never quit. To start off with some SBAs, we have a 30-year-old primary gravida at 37 plus 4 weeks, spontaneously conceived DCDA twin, and she is in established labor. Her antenatal course was uncomplicated. Ultrasound shows twin 1 cephalic, twin 2 breech, estimated fetal weight of 2.7 and 2.5 kgs. CTG is reassuring. She's 5 cm dilated, progressing well. The registrar wants to discuss the mode of delivery. The woman prefers vaginal birth is safe. Senior support theatre availability are confirmed. So what is the most appropriate management here? So here they were only worried about the mode of delivery and the woman is actually wanting for a vaginal birth. So these are some things we have to keep in mind. She's uncomplicated twins. The first one being cephalic, otherwise everything okay, and she's in active labor. So for this kind of patients, vaginal birth can be allowed. So looking at the options, emergency cesarean section not required, category 3 cesarean section again not required. Proceed with planned vaginal delivery, yes, we can proceed with. Looking at the other options of ECV and forceps delivery, not required right now. So we are going to proceed with a planned vaginal delivery. The next one, we have a 34-year-old multi with monochorionic diamniotic twins, 36 plus 6 weeks. She's undergoing induction. Twin 1, vaginal, good condition. Twin 2 is transverse lie with intact membranes, reassuring CTG. Cervix is fully dilated, presenting part is high. Obstetrician experience in twin delivery is present. Okay, so let's see. So twin 1 is delivered, twin 2 is in transverse lie. So the only indication of doing an internal podalic version is the second twin being in transverse lie. Looking at the options, section not required, IPV with breech extraction, well, that's what we're looking at. So we go ahead with that. Looking at the other options, external cephalic version, oxytocin, await spontaneous version, no. So the most preferable one is going to be an internal podalic version. Looking at the next question, we have a 27-year-old primary at 36 weeks with spontaneous labor, DCDA twin pregnancy. Antenatal course is uncomplicated. Ultrasound reveals the twin 1 is breech, twin 2 is cephalic, 2.1 and 2.2 kgs. CTG is reassuring. So at this junction, we see the twin 1 is already breech. 3 cm dilated and she is having good contractions. Now she is requesting counseling on the safest delivery mode. So which is most appropriate? So going back to the question, first one being breech, vaginal delivery still can be allowed, but the safest delivery mode when the first one is not in a cephalic presentation is always going to be a cesarean section. So most appropriate trial of vaginal delivery can be offered, but we have to look back at the question. We are looking at the safest delivery mode, which says a cesarean section. So option B, planned cesarean section is going to be the most suitable option here. Other options like continuing labor, strong contractions, ECV is not appropriate here. Looking at the next question, we have a 34-year-old IVF DCDA and she's at second stage, 38 weeks. CTG is going on. Twin 1, spontaneous vortex presentation. 5 minutes later, the CTG of twin 2 is showing recurrent late decelerations. The vortex, it is a vortex presentation. The head is at +2. Epidural is there. The obstetric team is ready. So what can you do here? Are you going for a cesarean section? Well, not required here. Ventus, forceps, oxytocin augmentation or observe further. The twin is showing recurrent late deceleration, which means we have to expedite delivery. Oxytocin not required because we know the contractions are fine. So the only option is, are we going to choose ventos or are we going to choose forceps? Immediate instrumental delivery where the fetus is compromised, go in for forceps. Next one, we have a 31-year-old monochorionic diamniotic twins. The twin 1 is delivered vaginally without any complications. After delivery, the contractions diminish. The cervical dilatation, again from 10, it's becoming 7. Ultrasound shows twin 2 with a reassuring CTG, no bleeding or distress is present. Are we going to do an emergency cesarean section? Are we going to do an oxytocin augmentation, an immediate breech extraction, operative vaginal delivery, or expectant management? Now let's go back to the questions here. So twin 1 is all fine. Twin 2, if you see CTG is okay, it is a cephalic presentation, so good chances of a normal vaginal delivery. The baby is not in distress, there's no bleeding. But if you see, the contractions have come down. Second thing is the cervix is also from 10 centimeter, it has come down to 7 centimeter. So the need of emergency cesarean section not required here. Breech extraction not required because we know the baby is in cephalic presentation. Operative vaginal delivery not suitable because the cervix has become from 10 to 7 centimeter. Are we going to have an expectant management or are we going to have an oxytocin? We have to use oxytocin in this case because it clearly mentions the contractions have ceased. Next one, we have a 28-year-old in labor, DCDA twins. They have epidural analgesia. Twin 1 delivers vaginally, and shortly after that, fetal bradycardia occurs and the vaginal examination reveals cord prolapse. Presenting part is quite high, -2, cervix is fully dilated. So what all we have to do? The best management here. Category 1 cesarean section, cord replacement, forceps, oxytocin infusion, or awaiting delivery. Now, awaiting recovery, definitely no, because it's cord prolapse, it's an emergency. Oxytocin infusion, again, not at all required here. Are we going to replace the cord? Are we going to do a forceps or are we going to take a category 1 cesarean section? Manual cord replacement is going to be the next immediate option. You can either do manual or you can fill the bladder with saline. But however, the best management for this woman is going to be a cesarean section. So you need to understand two kind of questions can happen. What is the next best management or what is the immediate management? Immediate will be you attempt for replacement of cord, but the best management is always a cesarean section. Next, we have a 26-year-old primey 40 plus 2 in established labor with epidural analgesia. Cervix is 7 centimeters. CTG has a baseline of 145, variability of 6, no accelerations, recurrent variable decelerations for 45 to 60 seconds. With shoulders and recovering rapidly. Contractions occur every 3 minutes. The liquor is fine. Maternal observations are stable. The on-fetal scalp stimulation, there is, of course, an acceleration. According to the intrapartum monitoring guidance, which is the most appropriate management here. Are we going to take for immediate category 1 cesarean section? Are we going to do a fetal scalplet sampling? Are we going to continue labor with conservative measures? Are we going to stop oxytocin and give tocolysis? Or are we going to apply fetal scalp electrode and expedite delivery? Okay. So here, if you see, we are just looking at the intrapartum monitoring here. Contractions every 3 minutes. So there is no hyperstimulation, so no need of stopping oxytocin. Fetal scalp blood sampling, it's not going to give us any different option here. Immediate category 1 cesarean section, well, it's not required at this point. Remember, category 1 cesarean section is only for dire obstetric emergencies. Are we going to apply fetal scalp electrode and expedite delivery? Now, the options of scalp blood sampling, scalp stimulation, scalp electrode, this is one of the gray zones that we deal with because most of the guidelines give different opinions and options about all of this. Now, in this case, if you see, the CTG is suspicious. It does not become pathological. So we need to understand what is a suspicious and what is a pathological CTG. We have variable decelerations, but we have variable decelerations, but however, the variability is fine, and there is an acceleration on stimulation, which means it is a reassuring part from the fetus. So you can apply some conservative measures and continue monitoring. The scalp stimulation, scalp stamping, or operative delivery is not ideal in this condition. Next, going into a 31-year-old multi, and she's on oxytocin augmentation. She's 6 centimeter dilated. She's having CTG changes. Baseline becomes 170. Variability is 3 for 50 minutes. There's no accelerations and late decelerations are present after most contraction. That means a late deceleration. The uterine activity, if you see 6 contractions per 10 minutes. So 6 and 10, we have hyperstimulated the uterus. Maternal temperature is 37. What is the most appropriate immediate action here? Maternal temperature is given here so that we correlate with the CTG changes. Okay. The most appropriate here, the first thing I would say is your uterus is hypercontracting, reduce it. So stop oxytocin infusion is going to be the most appropriate one here. Next one, a 24-year-old at full dilatation, the CTG baseline is 135, the variability is 5. There is a recurrent, prolonged deceleration lasting for 3 minutes with pushing efforts. Station is +2 occipital anterior. So why should you wait here? You'll have to deliver the baby out as quickly as possible. Okay, so you go in for an operative vaginal birth here. Let's look into some EMQs. We have a 25-year-old primey at 39 plus 5 weeks. She is in active labor with epidural analgesia. The cervix is 6 centimeter dilated. The CDG demonstrates a baseline of 150, variability of 5 to 10, and recurrent variable decelerations are there for 40 seconds. If you see the decelerations, they have a rapid recovery. The liquor is clear. The maternal observations are normal. On digital stimulation of the fetal scalp during examination, you have an acceleration also. Oxytocin infusion is not there. And according to the intrapartum CTG interpretation guidance, what is the most appropriate management? Now, whenever you come across any EMQs, try to do the cover test. Like, don't look into the options, read the scenario, and try to come to a best conclusion here. Everything seems fine here. 6 centimeter dilated. She's a primey. She's on epidural. The baseline is fine. Variability of 5 to 10 is also okay. There are variable deceleration, but still they are able to come up. And on scalp stimulation, accelerations are there. Okay. So these are all good points. Now, what are we going to do? Are we going to continue CTG? Are we going to reposition with IV fluids? Stop oxytocin? We already saw there is no oxytocin going on. Tocolysis, scalp stimulation, lactate, scalp electrode, amnio infusion. Not required all of this. Category 1 section, urgent cesarean section, hypotension, conservative observation, immediate delivery, or discontinue active pushing. Well, in this case, you just have to observe the woman because the trace is still suspicious and not pathological. Let us look into the next scenario. We have a 32-year-old multi undergoing augmentation for slow progress, and she is developing CTG abnormalities at 5 centimeters. Baseline is 170. We see the baseline is increased. Variability is less than 3. Again, the variability has become less for almost 45 minutes, along with the recurrent late decelerations. Uterine activity is 6 contractions in 10 minutes. So there comes a problem. The uterus is hyperstimulated. The first thing will be always stop oxytocin. Yeah. Next one. We have a 30-year-old woman in second stage labor. She is pushing actively for 45 minutes. The CTG is revealing repeated prolonged deceleration which lasts for 3 minutes during pushing. Cervix is fully dilated, head is at +2 occipital anterior. So according to the operative delivery principles, what is the most appropriate action? Well, you have to expedite delivery. So you're going to expedite with an instrumental vaginal birth. Now, going into the next scenario. We have a 27-year-old primey. She developed sudden CTG change after an epidural placement at 4 centimeters dilated. Baseline is normal, but variability is less. It has become 3 beats per minute. And if you look at the maternal BP, it is 85 by 50. So there is hypotension following an epidural. There are no deceleration. So which management step addresses the likely cause of the CTG? So it is because of the epidural. So we'll have to reposition the woman. We have to put her on IV fluids also. Okay. But do we have any other option here? Treat maternal hypotension. So if you look, we have two very close options here. One is repositioning and IV fluids. Second one is treat maternal hypotension. Now, in this condition, when the BP is very low, we look at hypotension. So, we go in for option L, which is nothing but treat maternal hypotension. Now, in this scenario, if you see, we had two very narrow options that can correlate with this. But however, the most appropriate one will be because of hypotension, we go in for treating hypotension. Going into the next scenario, we have a 29-year-old woman at 8 centimeter dilated. She has a CTG demonstrating smooth sine wave oscillations of baseline of 20 minutes without accelerations. There are no opioids, and she reports decreased fetal movements earlier also. So according to the CTG classification, what is the best management here? Well, CTG is showing smooth sine wave oscillations. So what are we dealing with here? This is a sinusoidal trace. Sinusoidal trace, especially in the background of reduced fetal movement, that means the baby is already compromised. Go in for immediate delivery. You're not going to sit into any further testing here. Let's look into more SPAs. We have a 27-year-old primary gravida, 40 plus 2 active labor with epidural. Cervix is 6 centimeter dilated. The continuous CTG shows a baseline fetal heart rate of 135. Variability is 6 to 10. Accelerations are present and occasional early decelerations with contractions. Liquor is clear. Observations are fine. Contractions are 3 by 10. On vaginal examination, everything is fine. There's no cord, no bleeding. The midwife is asking whether an escalation or intervention is required based on the CTG. Do we require? No, because the baseline is fine, the variability is okay, accelerations are also present. So you're just going to continue the routine monitoring here. The next question, we have a 32-year-old multi. She's on oxytocin augmentation. She's 8 cm. CTG has a baseline of 170 for 15 minutes. Variability is okay, 7. The no decelerations, temperature of 38. So this is one of the reasons why there is fetal tachycardia. Liker is fine. Contractions is 4 to 5. There is uterine tenderness and mild tachycardia. So what is the next thing you're going to do? Are we going to start with fetal scalp lactate measurement, stop oxytocin and assess for infection? Yes, this is something that we'll have to think about here because there is maternal temperature. Immediate operative delivery, no, she's only 8 centimeter dilated. Ignore trace, no, you cannot ignore it because there are some concerning features of tachycardia there. Or are we going to start maternal oxygen therapy? Oxygen therapy, yes, for a sepsis is required, but before that, you need to understand why there is a tachycardia. We have to rule out infection here. Next, we have a 29-year-old at 41 weeks, fully dilated. She's pushing for 1 hour. The CTG is showing recurrent variable deceleration of more than 60 beats per minute, lasting for more than 60 seconds with slow return to baseline. Baseline is 140. Variability is reduced to 4 beats per minute over the last 40 minutes. And it's again mechonim staying like her. Station is at +2 occipital anterior. Now, what are you supposed to do? You will have to deliver the baby out. Now, since it is at +2, you can go in for an expedite operative vaginal delivery. Okay. Now, let's look into the next question. We have a primary gravida, 39 weeks, has epidural analgesia, and she's on syntocinon infusion. The CTG shows prolonged decelerations to 80, lasting for 4 minutes, following a tachysystole. Cervix is 5 centimeter. Maternal baby is normal. Okay, so prolonged decelerations of 80 lasting for 40 minutes means there is something really bad with the baby. But how did it all start? It was following a tachysystole. Remember, she's on syntocinon infusion. So the first thing will be stop your syntocinon infusion. So next, we have a nulliparous woman at term showing a CTG with sinusoidal pattern persisting for 20 minutes. Now, whenever you have the sinusoidal pattern, understand you will have to deliver the baby out. So you have to do an immediate expedited delivery. Okay, let's see this question. Here we have a 30-year-old primey, 40 plus 5 weeks. She's on induction because of post dates. She's currently 4 centimeters and she's on Synto augmentation. CTG has a baseline of 155, variability of 4 to 6, no accelerations, and intermittent shallow variable decelerations. The liker is fine. Observations are fine. Contractions are 3 to 4, which is adequate. The midwife requests an interpretation and management because she feels that this trace has not come back to normal. So what are we going to do here? Okay, maternal oxygen, expedite operative delivery, not required. She's only in early stages, right? Just 4 centimeters. Reduce or stop oxytocin and reassess. 3 to 4 contraction is still okay. Continue monitoring without any actions or immediate fetal scalp lactate. Well, CTG, we'll have to interpret the CTG for which we are going to follow the 2015 FIGO guidelines. This is just a suspicious CTG, okay, because we just have recurrent shallow variable deceleration, which is again getting back to normal. So first thing is whenever you have a suspicious CTG, we have to look at the possible reversible causes. Oxytocin, well, maybe one of the causes, we'll have to see. So here what we are going to do is we are not going to sit and do any invasive measures or we are not going to expedite delivery because CTG is still in the suspicious range. Now, let's look into this question. We have a 33-year-old multi at 39 weeks, previous uncomplicated vaginal delivery. She's coming in established labor. She's fully dilated, head at +2 station. CTG shows a baseline of 130, which is fine. During pushing, the variability progressively reduces to less than 3 beats per minute over 15 minutes, absence of accelerations and intermittent late decelerations. Observations are fine, contractions are adequate, and there's an epidural in place. Delivery is expected but not imminent within the next contraction cycle. So, what are you supposed to do? You have to expedite delivery. And how can you do it? With using an instrumental vaginal delivery. So now let's look into an EMQ. So as mentioned earlier, for EMQ, we are going to follow the cover test. We're not looking at the options, we're just looking at the scenarios now. So our first scenario says we have a 31-year-old Mrs. Ritu Sharma. She is a monochorionic diamniotic twin pregnancy. She's 34 plus 5 and she's already come in spontaneous labor. Cephalic, both twins with the AFW of 2.1 and 1.2. So here is the catch where it's a discordance of 43%. The umbilical artery of Doppler twin 2 shows a absent and diastolic flow, again a concerning factor. And the CTG is currently reassuring, the labs are normal, and she is 3 centimeter dilated. So what are you going to do in such a condition? Well, now we are looking into the complications. So, well, in this condition, if you see, though both the babies are twins with a cephalic presentation, there is something that we need to consider here. There's a growth discordance along with Doppler changes. So, for this kind of scenarios, it is better to go for a cesarean section. So let's look into the options of cesarean section. Category 1, no, not required. Elective cesarean section, yes, you can go in for that. Since she's in spontaneous labor, you just have to take her. Immediate delivery after steroids, no, she's already in labor, so might as well take her immediately. So another options is cesarean delivery due to suspected TAPS. No, we're not suspecting TAPS here. This is just growth discordance. Okay. So next scenario, we have a 29-year-old Mrs. Elena, MCDA twins, 36 weeks in early labor. Now, what does our antenatal finding says? Says that your MCVA PSV of twin 1 is 1.7. So twin 1 is anemic and twin 2 is polycythemic. There is no high drops, both are cephalic and CTG is reassuring. So we have anemia polycythemia syndrome here. So let's look into the option. So category 1 cesarean section, elective cesarean section. Well, cesarean section is decided again here, but yeah, we can offer an elective cesarean section due to Doppler abnormality. Let's see if there are any other options which are very close by here. Suspected cesarean delivery due to suspected TAPS. Okay. Also, we have delivery in a tertiary center with neonatal transfusion readiness. Well, that can also be a suitable option here. Now, looking at the options, I feel option M, that is delivery in a tertiary center with neonatal transfusion readiness, might be very much appropriate in this scenario because of this twin anemia polycythemia syndrome. Yes. Let's look into the next one. We have a prime Mrs. Sana, DCDA twins in second stage of labor. So twin 1 is breech, twin 2 is scaffolding. The aftercoming head of twin 1 fails to deliver. The chin of twin 2 is impacted with the head of twin 1. Okay, so what are we dealing with here? We are dealing with interlocking of twins. So what are we going to do here? Let's look into the option. This woman definitely requires an emergency category 1 cesarean section. Okay, so we have one option of category 1 cesarean section for acute fetal compromise. Another one is an emergency cesarean for locked twins. Well, we know the fetus is compromised, but here, if you look at option J, it is more appropriate here because it is mentioning locked twins. So we go for option J, which says emergency cesarean section for locked twins. Now going to the next scenario, we have Mrs. Nadia Petrova, MCDA, twins, 32 weeks, twin 2 shows severe growth restriction. And the Doppler is showing reversed end diastolic flow. She's in early labor and CTG is equivocal. One thing we need to understand is it is only 32 weeks. Okay, severe growth restrictions along with Doppler changes. So what are we going to do here? We need to advise her for an emergency cesarean section. Well, we'll have to take her up because there is a fetal compromise here. So you can ask her for, I would rather go with, option B, which is a category 1 cesarean section for acute fetal compromise. Okay. Next, we have scenario 5, which shows Mrs. Lucia, 35 plus 6 weeks, monochorionic diamniotic twins. TAPS is suspected. The labor is advanced 8 centimeter. Both are cephalic and the CTG is normal. Okay. So CTG is fine, both cephalic, and she's already 8 centimeters. So just allow her to deliver. So proceed with monitored vaginal delivery for her. So how are we going to interpret CTGs? We need to have a structured sequence. You look at the baseline, look at the variability, then comes your accelerations, decelerations, contractions, and you have an overall classification. For EBCOG exams, you're going to use a FIGO classification, which is normal, suspicious, and pathological. The management decisions in the EMQs are all tied up with this classification. It's not just with the description alone. So you need to understand what is the background risk like, what is the background, whether the women belongs to a high risk or a low risk, and any other intrapartum or antenatal factors that can contribute to CTG changes. And also you're going to look at the current CTG status. The strongest indicator of fetal well-being is the variability. The normal is 5 to 25. Whenever there is reduced variability along with deceleration, it is suggestive of hypoxia. So, coming to decelerations, you have to be very careful. Are we dealing with an early decelerations, a late decelerations, or a variable decelerations? Always you look at the reversible causes of decelerations. Stop symptom, that is the most common cause. Reposition the mother, give her fluids if required, and treat the tachysystole. Accelerations are always reassuring. It is a sign to say that yes, your baby is doing fine. Whenever there is reduced variability, it doesn't mean you're going to do an immediate delivery. You have to think about the fetal sleep cycle, use of labor analgesic drugs, and prematurity. What are the recognized red flag patterns that you have to keep in mind? One is whenever there's a sinusoidal pattern, persistent late decelerations is another thing. Prolonged bradycardia, there is absent of variability with decelerations. Now, whenever these are present, think of expediting delivery. You never interpret CTG in isolation just for the trace. You're going to look at the stage of labor, the maternal parameters, meconium, again, a very important thing to look at, infection markers, and use of oxytocin. So let's look into some more questions here. We have another EMQ. So we have a 29-year-old primee. She's 40 plus 1 weeks on oxytocin augmentation. The finding says the cervix is 9 centimeter dilated. And what is our CTG showing here? Well, CTG is showing something very, very different here. That means there is a prolonged decelerations for 4 minutes. The contractions are 6 per 10. The most appropriate immediate action. Well, prolonged deceleration not picking up, you have to take her for an emergency cesarean section, category 1. But what is the most appropriate immediate action here? Your contractions are 6 by 10, so stop oxytocin infusion. Looking back at the options that we had, yes, we go with option C, which says stop oxytocin infusion. Next one, we have a 35-year-old induced labor at 41 weeks. The CTG shows a baseline of 135. Good. The variability is again normal. We have 8 typical variable decelerations, thick meconium, and cervix is 4 centimeters. What are the key factors you have to keep in mind? The baseline is okay, the variability is okay, but there are recurrent atypical variable decelerations. So that is one thing that needs to be considered. Second thing is the liker is thick meconium. So there are 2 factors that we have to keep in mind, and she's quite early in her labor. She's only 4 centimeters. So yeah, CTG needs to have a review. So who can review? You can call in your consultant for review here. So yeah, we can go with option K, which says escalate to senior review with continuous surveillance. Now let's look into the next scenario. We have a primee who's 38 plus 3 weeks. She just received PET in 30 minutes. The CTG shows a baseline of 130, variability of less than 5, no decelerations, accelerations are present, and maternal vitals are normal. We need to understand that variability has reduced, but there's also a factor that is receiving PET in 30 minutes earlier. So we are just going to observe her. Going into the next question, we have a second gravida, 39 plus 4 weeks in active labor. Baseline is 145. Variability is normal. There are recurrent late decelerations. The cervix is 6 centimeters. The maternal BP is normal. So, what is the best next investigations or action? So baseline is fine, variability is okay, but recurrent delayed decelerations at 6 centimeters. And without being on oxytocin and the BP being normal, that means the reversible causes are quite less here. So what are we going to do with such a woman? We can offer her a fetal scalp sampling if required. So these are some questions that I had taken on the module labor and delivery, which is going to target your CTG classification and also management of twins in delivery. Thank you, and I hope this would definitely help you prepare better for your exams. Thank you, and wishing you all the best.